Quality Watch is an educational production of IPRO. Opinions expressed reflect the views of the speakers only and not those of any company or agency. This podcast is intended for private, non-commercial use only. Please visit ipro.org to read our full disclaimer and terms and conditions.
Welcome to Quality Watch, the podcast focused on healthcare quality improvement. Quality Watch is a production of IPRO, a trusted partner of federal and state agencies working to measure and improve the quality of healthcare for all. I'm your host, Dr. Edison Machado, Senior Vice President of Strategy Solutions here at IPRO. In today's episode, we'll talk about the use of psychotropic medications in youth in foster care, the newest COVID-19 vaccine, and we'll take a deep dive into school-based health centers. But first, a few quick headlines and updates from around the nation and here at IPRO. The Centers for Medicare and Medicaid, or CMS, recently published proposed rules regarding Medicaid managed care access, finance, and quality. While the public comment period for the rules have closed, IPRO's Medicaid Managed Care Department continues to review the proposed rules and will be available to advise and assist states on compliance with any of those proposals. As summer ends and kids return to school, COVID-19 infections are back on the rise. Both hospitalizations and deaths are up, with those over 75 most impacted. The FDA recently approved updated COVID-19 vaccines and authorized them for emergency use. The new monovalent vaccines target variants of the COVID-19 virus that are currently circulating and are expected to provide better protection against serious illness, hospitalizations, and death. However, with the FDA's announcement on September 11th, the bivalent Moderna and Pfizer-BioNTech COVID-19 vaccines are no longer authorized for use in the U.S. To address the staffing challenges that many healthcare organizations face, HHS has launched a new workforce initiative that will invest more than $75 million in scholarships and tuition reimbursement to make it easier for individuals to enter nursing careers. And finally, HHS recently issued a proposed rule that seeks to establish comprehensive staffing requirements for nursing homes, including national minimum RN staffing levels. Public comment period for this rule is open for those that are interested. In all 50 states and the District of Columbia, school-based health centers provide primary and preventive care for children who would otherwise lack access to that care. Here in New York State, IPRO works under contract with the Department of Health to monitor school-based health centers across the state. Joining us today is the person overseeing that work here at IPRO, Terri Greco, Senior Director in the State Healthcare Assessment Department. Welcome, Terri.
Thank you for having me, Eddie. I appreciate being here.
Great. Well, let's get started at the beginning. So how long has IPRO been engaged in the work with the state?
IPRO's been working in collaboration with the New York State Department of Health on this initiative since 2010. We're about to enter into our third contract period with them. And over that period of time, we've conducted reviews at well over 500 school-based health centers and school-based dental programs. A very exciting project, very important project that I'm happy to be a part of.
Well, it sounds that way. So, Terri, what types of services are typically provided by these school-based health centers?
So as you had mentioned, school-based health centers provide primary and preventative services, both medical and dental. So in the medical realm, comprehensive physical exams, vaccinations, vision screenings, behavioral health screenings, and diagnosis and management of acute and chronic health conditions such as asthma. School-based dental programs provide preventative care such as oral exams or cleanings. They may be a sealant-only program, so there are programs for third grade students, grants available to provide sealants. They also might provide restorative care, for example, filling a cavity. They also provide classroom education, so teaching children how to brush their teeth and how to care for their teeth, and also screen for disease, provide referrals for other specialty services such as orthodontic services. And the thing that's interesting about school-based dental programs is that they are very innovative in the way they reach children. So you might see a clinic established in a school that when you walk into it, it looks very much like a regular dental office that you would see in the community. But sometimes that space is not available, and so providers have portable equipment that they can set up in one day. They'll see all of the students in that school for as many days as is needed to rotate through the entire cycle of children. And then they pack that equipment up and they move on to the next school. And some programs even have a dental mobile van, which are really interesting. They're full service clinics on wheels. And so they will drive from school to school, park for a period of time, serve children, and then move on to the next school.
Thanks, Terri. It sounds like these centers really provide quite a list of services, and it's clear how important a role they play. Do we know how many students receive care from these school-based health centers across the state?
So based on the last data published by the Department of Health, which is for 2021, it seems that over 157,000 children are enrolled in a school-based health center throughout the state. And for many of these children, the school-based health center is their primary care provider. And also, this may be the only dentist that child has ever seen.
Thank you, Terri. So I want to shift gears a little bit and maybe talk a little bit about IPRO's role specifically. Along those lines, what is the organization's role in ensuring that these centers meet quality standards?
So over the years, IPRO has worked in collaboration with the Department of Health to complete and create a set of standardized tools that we use that are based on regulatory requirements, guidelines issued by the state, and guidelines from other entities such as the American Academy of Pediatrics. And so what we do is we identify what those core requirements are, and we set up criteria for what the minimum threshold is in terms of the expectation of performance. And then we take an agreed upon list of providers throughout the state. We work with New York State Department of Health to develop a schedule, and we contact those programs in advance and we let them know that we're coming. So it's different from other audits that they may experience because it's not intended to be kind of gotcha. It's not punitive, right? It's supposed to be a learning experience. It's an opportunity to improve the services for children throughout the state. So we look at this as a collaborative venture, and we hope that a program will walk away from the experience feeling as though they've learned something that will help them improve their services. We are available for technical assistance throughout the process. So if a program administrator has a question, they're not sure what to have available for us when we come, we're happy to answer those questions. We really want them to have every opportunity to put their best foot forward. At the end, we review with them some of what we've seen, and then we formalize the end of the review with a report. And the report identifies areas where they didn't meet the minimum threshold. And so then the expectation is they will develop a corrective action plan, and they will address what needs to be changed in order to improve their performance going forward.
Well, that's great information, and I'm glad to hear that collaboration is really the defining factor here with regards to the work. Speaking of which, who is on the team that does this work at IPRO?
So we've been very fortunate. We've had a consistent team of registered nurses, dental hygienists, and other quality improvement specialists, many of whom, including myself, have been with this program from the very beginning in 2010. And because we have such a long-standing relationship, it allows us to have excellent rapport with our counterparts at the Department of Health, but also with program administrators in the community.
Well, that's great. I believe you touched upon this a bit, Terri, already, but what type of metrics or measures do you use to measure the centers? And more importantly, how has their performance changed since the inception of the program?
We did talk about some of the regulatory requirements and guidelines that we use. It is primarily based on a document that was issued by the Department of Health, which is called the Principles and Guidelines for School-Based Health Centers. So that document outlines all of the contractual requirements, and we use that as the basis. So it's measuring things like, for example, school-based health centers are expected to enroll at least 75% of the student population of the school in the school-based health center. So when we go out, we measure to see where, approximately how many students have they enrolled and whether or not they're meeting that requirement. We also look at things like supervision and staffing. So we're doing a credentialing review. We're making sure that licensure is up to date, that training, emergency care training, and BLS training is all up to date. We also look at things like supervision for the clinical staff. So, physician assistants, behavioral health providers, there's requirements for supervision. So are those minimum requirements being met? And then we look at things like core services. So are they providing referrals for services that they don't offer on site? Are they following up on those referrals to make sure that they're actually receiving the services that were recommended? Are they communicating with primary care providers when there is one involved? Because that's really important. You don't want to have a duplication of services, and you also don't want to have gaps in service. And then clinical outcomes such as, are the child's immunizations up to date? Did they have an annual comprehensive physical exam? Did they have an oral health screening? Did they have a behavioral health screening? Really important. And then, are they providing appropriate anticipatory guidance to both the student and the family? Because if you think about it, if a student is receiving medical services in a school setting, it's really important to make sure the family is still kept in the loop, right? So how are they doing that? What method of communication are they using to make sure that families know what might be needed?
Great, Terri. Appreciate that. Just changing gears a bit once again. Obviously, COVID is back in the news, unfortunately. My question really is, how has COVID impacted students who use these school-based health centers?
So I guess if you think about it first, where are these school-based health centers located, right? So you will find school-based health centers in communities that have been designated as high risk for a bunch of reasons. So maybe they're looking at data about schools where there is a large percentage of the student body eligible for free and reduced lunch, right? Areas that may be experiencing high rates of crime, poverty, homelessness, food insecurity, or also rural areas of New York State where healthcare is not easily accessible, either because of distance or even because of things like spotty broadband service. So telehealth isn't even an option. So when you think about those communities, and now we think about COVID, right? So we already know that these are communities that were struggling with health equity issues for a variety of reasons. And now you add COVID on top of it. These are probably the same communities that experience the impact of COVID most profoundly, right? So we know that data from National Institute of Health tells us that BIPOC communities, right, were disproportionately hospitalized and died at higher rates than the population as a whole. And we also know that when New York State went on pause in March 2020, the schools were closed. And so that haven for many students, right? The place where they could be guaranteed at least 2 meals, the place where it was safe, that haven no longer existed. And so children experienced isolation. They had a lack of socialization, and they also had profound exposure to family stressors, right? So these are families that maybe experienced loss of employment or financial strain, housing and food insecurity, or even death of a family member. And so during that time, we saw an increase in youth anxiety, depression, substance use, and even attempted suicides. And those socioeconomic impact, those health issues, behavioral health issues, they persist into 2023.
Wow. I mean, that's really something, and, very disappointing, but understood given the situation. Can you talk a little bit more about how those adverse childhood events or things they're going through could impact these individuals into adulthood, and maybe a little bit on how these school-based health centers are trying to help these students?
Yeah. So the research tells us that, you mentioned adverse childhood events, those ACEs, right? So there's actually a way to quantify them based on the number of adverse experiences a child might experience and whether or not it's treated, right? So it's not to say that if a child experiences multiple adverse events, that they are destined to have difficulties with things like employment or relationships or chronic health issues. But left untreated, the likelihood that those adverse events will have a negative impact into adulthood increases. And that's where the school-based health center is so critical, because that is where the student is, right? They meet the student where they are during the day. They have access, easy access, because the child is there. And because they are familiar with community-based programs, and because the expectation is that they're maintaining a communication with the child's family, they're really in a unique position to be able to outreach and then provide referral and follow-up. And also, school-based health centers are sponsored primarily by hospital networks or federally qualified health centers. So when you think about the array of services that are available under those umbrellas, the idea of making a referral is seamless for a family because they're staying within the same network. And so you're also removing barriers to things like, well, how am I going to pay for it? And will they accept my insurance? Because the school-based health center, being part of the network, already knows how to navigate that on the family's behalf.
Well, Terri, you've given the listeners quite a bit of valuable information. If they're interested in learning a bit more about the work you and your team are doing, where can they find that?
Our program information can be found on IPRO.org, and you would just search under School-Based Health Center Program Performance and Quality Improvement.
Great. Well, thank you, Terri. And on behalf of a father of a 5 and a 7-year-old, I want to particularly thank you for the great work you do and for the time you've spent with us. Links to more information, as Terri has mentioned, about this work can be found on the website at IPRO.org and in the Quality Watch show notes. It's time for us to crunch some numbers in our Data Watch portion of the program. Coming off our conversation about school-based health centers, we're taking a look at data points concerning youth in foster care. A study presented at the 2021 AAP, or American Academy of Pediatric National Conference, found that 1 in 3 children in foster care were prescribed psychotropic medications. However, among Medicaid-covered youth not in foster care, that percentage goes down to 8%. The study included close to 400,000 children on Medicaid in Southeast Texas. Of those, 8,426 were in foster care. In California, a series of legislative reforms resulted in a 58% reduction in the number of antipsychotic prescriptions filled for youth in foster care from 2010 through 2020, and a smaller decline in the number of psychotropic prescriptions during that time. IPRO is currently conducting studies around this very topic in 2 states as part of our work as an external quality review organization, or EQRO. That's it for this episode of Quality Watch. I'm Dr. Edison Machado, and on behalf of IPRO, thank you for listening. To learn more, visit our website at ipro.org. That's IPRO.org. And if you enjoyed this podcast, please leave us a comment and subscribe wherever you listen to podcasts. We'll be back next month with more. Until then, we'll be working on better healthcare realized.